Okay.
All right. Okay. So, all right, you can do this either way you want to. You can either prove your hypothesis, or you can get rid of these differentials.
Okay.
What do you want to do?
I'm gonna go to prove the hypothesis.
Okay, way you go then. I'm your patient.
Okay. Do you have pain with gripping?
Yeah.
Is it tender to touch?
I don't know. I don't touch it.
Okay.
Or are you asking for the test?
I guess that's more of a test then.
Okay. Yeah, tendon's tender.
Okay. Is it weakness with extension, wrist extension?
Is it weak? No.
I guess what does the wrist extensor's muscle test look like?
It's strong enough.
Strong. Okay, so not like fatiguing or anything
No.
like that there. Okay. What about repetitive testing?
It doesn't get any weaker.
Okay.
Are you happy with your diagnosis, or have you got more to do or ask?
I mean, if it's tender, right in the spot and pain with gripping, I'm pretty happy with that.
Okay, so what's your cluster or essential illness script for this? For tendinopathy, common extensive tendinopathy.
Tender to touch of the lateral extensor.
Yeah.
Pain with gripping.
Yeah.
And I know there's more, but I'm blanking on.
Sorry, say again.
I'm blanking on the other ones.
Okay, what about painful wrist extension?
Okay, painful wrist extension then.
So no, you can't get away with that easily. Why did you ask about weakness? Is weakness part of the illness script?
No, it's not.
So why did you ask about weakness?
Because I couldn't remember the illness script.
Okay, but when you test, all right, I don't want you to remember this stuff, but you've treated tennis elbows, yeah?
Yes.
Okay, so when you test it, you resist elbow extension. That's one of your tests, isn't it? To resist wrist extension.
Yes.
Okay, are you worried about whether it's weak, or are you worried about whether it's painful when you do it in the clinic?
I'm looking at both.
Weakness isn't part of this.
Okay.
It's pain. Like this is a tendinopathy, so it's painful rather than you're interested in weakness. You might be interested in that for the etiology, but not for the diagnosis.
Okay, that makes sense.
Okay. Okay, now let's look at bias correction then. Okay. Your first bias is what here, do you think?
I would look at the joint, like joint.
No, I don't mean that. What bias do you think is likely to be playing a role here, if any of them are?
Maybe too early of like closing.
No, probably not. You've got enough information to say it's tendinosis.
Okay. Like familiarity bias.
Yeah, availability. Yeah, availability. So what are you going to do about that?
Do a differential diagnosis.
There you go. Good. So let's have a look what we got here. We've got biomechanical dysfunction, and we've got stress fracture. We've got referred pain. Yeah.
Okay. Yeah.
All right. Let's work with those then. All right. So do you want to prove them or get rid of them?
I just thought of another differential would be like ligamentous instability.
Okay, so lateral collateral ligament problem. All right. Okay, so how are we going to get rid of this? Or are you going to try and prove each one? You're doing bias correction now. You're going to try and prove each one or disprove each one.
Disprove each one.
Okay, don't ask it. Don't say it as a question.
Okay.
Okay, so biomechanical dysfunction.
So we could ask if they've had this any prior episodes before, but also looking to see.
That doesn't disprove it. You want to get this done as
Okay.
quickly as you possibly can.
Okay, so just look at the joint glides.
Even that's not quick enough, nor is it sensitive enough, really, to disprove it.
Okay,
What's your quick test for mobility of a joint?
doing like a quadrant test.
Yeah, and that'll test all the joints, because you've mentioned radio ulnar, but you've got 3 other joints that can produce this pain. So if you do the quadrant test, you get rid of all 3 joints if it's all negative. Okay.
Okay,
So what I'm going to say to you is that there's no pain generated from the quadrant test, but the ovoid of motion is a bit abnormal.
which part of the motion?
Ovoid. That is one of the quadrant tests is abnormal but not painful.
Okay, so to me, that tells me it's not the pain generator, but it may
Good.
be part of the etiology.
Yeah, that's good. That's exactly right. Stress fracture.
Palpation.
What are you going to palpate?
Like the joint lines.
How do you get the joint line from this?
Well, I guess you would just like you do ultrasound or like a vibration test.
Okay, let's say that the ultrasound is negative. Are you happy there's not a stress fracture in there?
No, not necessarily. So
Why not?
I don't know what like the specificity for that would
Yes,
be.
exactly. You have no idea how good that is for testing. It might be great, it may not be great. You don't really know.
So for this one, based off of, is the pain getting increasingly worse?
Well, it was, wasn't it? That's why he cut our playing tennis.
Yeah. Like if he's not using it, is it still bothering him?
No, it's sort of leveled off a bit. But then so would a stress fracture.
Mm.
Let's come back to it and see if you can figure it out in a minute. What about referred pain?
You could do just like again, like a neck
No,
or
you don't have to
shoulder
do that either.
quadrant.
If all of the local signs around the elbow are negative, then there is no local pathology that you can reach, which means it isn't musculoskeletal. So you may have something in the bone, some form of tumor or something, but it's not musculoskeletal that we can deal with, or it's being referred from somewhere else. But you establishing the neck as a mechanical dysfunction does not disprove anything about the doesn't prove anything about the neck being the pain generator for the elbow. Does that make sense? So
So you're saying because sorry, so you're saying because you're able to palpate and you have that tells you right there that that's where the pain's coming from.
Yeah, you've got local signs. So you've got tenderness and you've got isometric wrist extension positive.
Okay.
And it's painful on dripping with the head as well, which really isn't the neck. So everything about this says it isn't referred. So you don't have to do a test for this. You've got enough local signs to say that.
Okay.
Okay. Lateral collateral ligament.
Stress test.
Or palpate it. If you can do it. And you should be able to do it without palpating the tendon. Okay.
Okay.
All right. So everything you've got there is suggesting this is a common extensive tendinopathy. Is it a tendinitis or a tendinosis? Stage it.
Last 3 weeks, I guess. I would say, I mean, is it pretty acutely painful right now? I would say tendonitis then.
I don't know, you haven't asked me about the intensity of the pain.
Okay, what's the intensity of the pain like?
Not terrible. I just don't like it. So when I play, it hurts, so I don't play.
Okay. So to me, I'm going to say tendinosis now.
You got some other tests you can add to this. So what are they?
Is there like swelling present?
No.
Okay.
All right, let me ask the question a little bit differently. What's the difference? Give me 3 or 4 signs or symptoms that will differentiate tendinosis from tendonitis.
So for
one of them was the severity of the pain, yeah.
Severity of the pain, like the acuity of what's going on, like I would say within the last few days, if it was pretty acute.
Oh, hang on a minute. You're talking about time. Now, you can't do that with inflammation. Acuteness can refer to time. That is, it's only been present for a short time. That's acute. Chronic indicates long time. But if you're talking about inflammation, that's not true at all. It's the actual pathology that's going on that says it's a tendonitis or a tendinosis. One's degenerative and one's inflammatory.
Okay.
All right. Now, you've got things like palpation tenderness, like if this is a tendonitis, it's exquisitely tender. Yeah.
Okay.
Obligate functional loss. They can't do what they want to do with a tendonitis. Swelling, as you said. Painful weakness on wrist extension in this case, but painful weakness and pain and spasm usually on stretching the muscle. So these are very different things. So don't just concentrate on one thing. They're completely different from each other, and they require different treatments. Okay.
Okay.
All right. Not bad, but you need to look at this as a whole. Like, I think you're looking at bits and pieces here without looking at the whole thing. Your process is, they got pain on the lateral elbow. What could be causing it? I'm going to go for a common extensive tendinopathy. You prove that, then you stage it. There's all one package, and then you look for etiology, which is the other thing. There's no good etiology here for a tendonitis. There's no obvious cause.
Right. Okay. That makes sense.
Okay. All righty. Caleb.
Yep, I'm here.
Okay.
I'm here.
All righty. Okay, where's it coming from?
Well, you said there's an abnormal joint motion at the elbow, so that's where I would want to start.
Okay. So what are you expecting might be causing this at the elbow?
So I would potentially be expecting an abducted ulna.
Okay, how does an abducted ulna cause tennis elbow?
It can alter the obvious one is it just alters mechanics. And so by altering mechanics, not everything is happy with where it is lying.
I need something a little bit more specific than altered biomechanics.
So the tendon has more tension on it than normal.
Does it? Like if you think about it, when you contract your wrist, when you're gripping something, the hand is just out of neutral. It's slightly extended. It's just out of neutral. So will an abducted ulna make that much difference to the tension of the muscle?
No.
Okay, but at least you gave me one reason. If you're going to, all of you now, if you're going to cite length tension relationships, you need to understand what that means and be able to explain it on the exam. There's nothing more irritating to an examiner when you throw out a term like that and then can't follow it up. Okay, it's annoying. Just make sure you understand the terms you're using.
Okay.
All right. Okay, so abducted ulna. All right. How will you, okay, I'm your patient. Tell me the test you're doing to prove it's an abducted ulnar, and I'll tell you the results.
I would look at the position of the radius and the scaphoid at the wrist.
Why?
Because if the ulna is abducted, then it's going to distally push the radius into the scaphoid. Not the radius, sorry.
Yeah.
No, yeah,
No.
never mind.
All right, I'm getting confused now. No, it
Yes,
doesn't.
never mind. Yeah, never mind. As soon as I said it, I was like, nope, that's wrong.
All right.
Um,
Also, when you're assessing positions of bones, it's not the easiest thing in the world to do. It's easy to say, but it's not that easy to do. You've got to remember the amount of abduction and adduction that's occurring at the ulnar-humeral joint is minuscule. But if you actually measure the angle changes, it's almost nothing there. So the effects are going to be cumulative, and you're not going to see a massive change in the position of these joints. You might see the hands, the wrist, the hand and wrist is a little bit more abducted. Hang on. We'll talk about here. Abducted. You might see that, but let's do it more direct. Don't keep being indirect here. You've got an abducted
Okay.
ulnar. What joint are you going to examine?
I'm going to look at the ulnohumeral joint.
Good. So tell me the test you're doing and I'll give you the results.
I would start with just add an abduction of it and then compare it to the other side.
Okay. So actually, you can give me the results. What are you expecting with this? What will adduction do? Will that be positive or negative?
What will adduction do?
Adduction.
That will be negative.
An abduction will be positive.
Yes.
Okay. Can you define an abducted ulnar for me? Is it sitting in abduction or adduction?
It's sitting in abduction.
Okay. So what movement can't it do?
Abduct.
It's sitting in abduction. What movement can't it do? If I've got a flexion subluxation at C5-6 on the right, what can't the right facet joint do? Flex or extend?
It would be stuck in flexion, so it can't extend.
Okay, this is stuck in abduction, so what can't it do?
So it can't adduct.
Yeah. Okay, so that's
Yep.
positive. The other one's
That's
negative.
positive. Okay.
Any other tests you want to do around the elbow?
Not that I can immediately think of.
Okay, now the joint, this joint isn't too bad for this. You can get away with it on this joint. You can't get away with that on other joints. Simply because this is sort of not an individual movement. If this was in the shoulder, okay, and you tested abduction, you found abduction was limited, what else would you do to the shoulder?
If the shoulder is limited in
Shoulder,
abduction,
you couldn't abduct the shoulder. What's your next move after that?
I'd look at the AC joint to see how that's moving.
Nope. What could limit abduction at the shoulder?
A tight pec.
What else?
I mean, be a muscle problem with the supraspinatus.
Yeah, you said that. What else other than muscle? What about the joint?
Yeah, I was going to anteriorly translated,
Well, what's the glide for abduction?
inferior,
Okay, so what's the glide for adduction at the ulnohumeral joint? Okay, what's the shape of
Lateral.
the ulnar humeral joint? What type of joint is the ulnar humeral joint?
A hinge.
No, we don't have hinges in this job. You got ovoids and you got cellars. You got modified and unmodified. What's the ulnar humeral?
Not an ovoid.
Okay, so it's a cellar.
Yeah.
It gets treated as an unmodified cellar, but it's a modified cellar, but that doesn't really matter. So one of these surfaces is concave, one of them is convex, or it's concavo-convex. One movement uses a concavity, the other movement uses the convexity. Yeah?
Yeah.
So if I flex and extend, which way does the ulna glide on the humerus during flexion?
During flexion, it will glide anteriorly.
Okay. So is that concave or convex for that movement?
Concave.
Okay, so it means that the other joint has to be convex. The other direction of glide has to be convex. Yeah?
Yeah.
Okay. So what's the glide for adduction? Medial or lateral?
Lateral.
Okay. Yeah. That's your definitive test for this. All right. It's always the glides that are definitive, not the movement, not the physiological movement. Okay, so you've got an abducted ulna. Are you satisfied with your etiology assessment?
No. I mean, that'd be the first thing that I wanted to look at. And then
Okay,
if it's
well, you found
abducted,
it. All right, you found it. Now what?
now I would try to manipulate it to see if that changed any of the symptoms.
No. Because there are other etiologies present, maybe, and you don't know. As soon as you manipulate this, you change everything. You change neurophysiology and you can change the mechanics of adjacent joints. So no, you've got to pick up the etiology and find out what's happening.
Okay.
So where do you want to look?
The next place I would look is the thoracic spine.
Okay, explain that to me. Why?
So I would go to the thoracic spine just because you're not going to like this answer very much, but
It's probably a good idea not to give it to me then, but never mind.
just anecdotally, I've found that a lot of my patients that have had lateral epicondylitis or epicondylosis, they've had stiff thoracic spines, and I've gone in and mobilized those, and in some cases manipulated them, and then their pain has gotten better.
I have no problem with anecdotes, but you're going to have to explain how that happens to me. I've got no problem with using experience for this. But at this point, I expect you to be able to translate that into a language that I can understand what you're doing. So I know that you understand why that's working. If you say I don't know, that's fine. But you should be able to trace out a reasonable pathway for that to contribute towards the tennis elbow. But we'll come back to that in a minute. All right. So how are you going to, you've got a lot of joints here to assess. So how are you going to assess the thoracic spine for this?
I would start in seated and do the flexion extension.
It's going to take too long. Like you really need to be looking at the wrist, T-spine, cervical spine. At some point or another, all of this is going to be looked at, and possibly even the shoulder. So you need quick tests again. You need to get through this, get them out of the way, and move on. Yeah.
Yeah.
So if you want a quick screening test to see if the thorax is either dysfunctional or dysfunctional and symptomatic, then what's your test for it?
Seated rotation is what I would do.
No, that won't do it either. PAs. It's the most stressful thing you can do to individual segments. You'll get individual infills from it, and that's not bad for actually getting rid of ideas about it being part of it. Do PAs, move it out of the way. Or if you're going to do movement tests, do quadrants again.
Okay.
Okay. But don't go into a full exam because it's unnecessary mostly. Now let's come back to the thorax. How does that contribute or cause a tennis elbow?
So if I'm trying to think this through in my head first. So if there's a subluxation in the thoracic spine, then there's going to be some kind of reciprocal change, probably in the CT junction.
Okay.
And then that could cause a neurophysiological change, whether that's AXT or something like that. I know it's a terrible
Before we
explanation.
go,
But
you listened to Shannon's thing here, and there was no weakness of the wrist extensor muscle. Yeah.
correct. Yep.
So is there an AXT problem?
No,
Okay. New explanation then for the thorax.
I don't have one.
Okay. All right. You really need to think about it. Okay. And it's not just for the exam or anything else. If you hadn't brought it up, you wouldn't have got asked it. But you're using this as part of your treatment. You need to be able to rationalize what you're doing to yourself, if not to anybody else. You need to know what you're doing in your own mind. This is where, honestly, mind maps help. They really do. But this is always the same with etiology, all right? You've got mechanical, neurophysiological, and neurological. And you investigate each one. So you started off mechanical, which was the elbow. The wrist is the next one that's has a huge bearing on tennis elbow. If that's hypomobile, then that can stress out the muscle in the same way. That is, I think, my explanation for this would not be length tension, although you can use it again. But my one would be that basically it's been overworked because the wrist can't get into its full exertion position. That is, it can't get enough radial deviation and extension to satisfy the proprioceptors in the wrist. So that says contract harder, so you overuse the tendon. Same thing if you've got a hypomobility in the wrist, it will do exactly the same thing. So that would be my explanation here. Now, whether it works, but whether it's true or not is a different animal. But that's my model. You need models. Okay, you need models. Otherwise, you're just sort of floundering around and not really understanding what you're doing. Experience is fine. Pragmatic practice is fine. But this goes beyond that. You need to at least have a model for why you're doing something. Okay, and it comes down to really organization of thought processes. How do you organize the way you think about the information that you're getting? And you can organize it any way you want to, but there's got to be some form of organization behind this.
Okay.
All right. I've got all of you now, this is everybody. There's a 70% pass rate, well, not 70% pass rate, there's a 70% pass mark on the oral practical. Now, if you've got the techniques down, the examination and the treatment techniques, that bites really a long way into that 70%. Where you're particularly weak, and it's not that it's just you're not thinking about this, you're concentrating on the technique side of this, which is fine. It's the clinical reasoning, the etiology that you need to smarten up on a bit. Because if anything's going to fail, it'll almost certainly be that and not your practice. Okay, it's your theory behind it and the way you're thinking about this. And it's actually quite a forgiving oral practical exam, but it only goes so far. Okay, so concentrate from this point on, use the techniques in your clinic, but concentrate your thoughts on how you find out the causes of this, and start looking. If you're not already looking for them in your clinic, start looking for them and organize it: mechanical, neurological, neurophysiological. They're your etiologies. Okay. Any comments from anybody? Or questions?
Jim,
Yeah,
all right, so when you were asking about the abducted ulna, and
yeah.
I don't remember if you said how does it get there or what does it do to cause
Well, that's the next
the
question, isn't it?
problem. So
Yeah, how
is
did
there
the
an
abducted
answer?
ulna get there? That's the next question you got. But we don't take you that deep in this exam. Can do, if you ask us to. Did I misunderstand what you're asking then?
No, I just was trying to follow. It's trying to follow your line of questioning, and then you were asking him, well, what? I guess you were asking him based on what he was saying, but I thought there was going to be like there's an answer, and I don't know what it is.
What? Why the abducted ulna's there?
Yeah.
Well, there's got to be degeneration in the joint for that to occur. It has to be degenerated. So now you start looking for stresses that will apply to the elbow. And that could be over time. It could be anything. If you're playing tennis a lot, it could be bad technique. You could have had a fall. Could be anything. And you could go looking for it. You may or may not find it. The further you get into, like if I've got an etiology for his tennis elbow, which is his elbow joint is subluxed, then I've got to be looking for that. That may be something like axoplasmic flow coming from the neck. Then I go, okay, well, why is the neck causing the compression of axoplasmic flow? So that goes on again. And the further away you get from the immediate symptom source, the less likely you are to find an answer. And eventually it happens. I have no idea.
Okay.
But that's what's going to happen to you. If you keep on following the trail through, at some point, and it may not be that long, at some point, you will say, I don't know. For the hip, for example, that might be more direct. The subluxations in the hip may have something to do with the geometry of the hip, the way the hip is structured, anteversion, retroversion, increased Q angle, decreased Q angle of the neck, of the femur. Any of those things could degenerate the joint. That one you'll never know about. So eventually,
Jim, are you going to be doing the oral practicals?
why?
Because I need to know if I need to book a trip somewhere else.
Oh dear. This should be fairly straight. This should be straight down the line for everyone doing the exams. These are not unusual questions to be asked. This exam is about testing your technique and testing your knowledge and testing your ability to hunt down etiology. You'll get the same questions off of everybody.
Right.
Okay. So where are you going to fly to?
somewhere far away.
No, where we're not. Honestly,
Yeah.
the failure rate on this is not very high. On the practical exam, it's not very high. You want to see a failure rate, you need to look at the M9 exam, as far as I'm concerned. That one I expect expertise from people. You lot, I don't expect that sort of level from you. And neither does the other examiners. Okay. So don't get too panicky about this. But you need, if you're not, after module 8, what I found is when I teach this stuff, people panic after module 7 and module 8 because they realize just how much they're not working on this. Now, you're different, your group's different, because you actually have a continuum of education all the way through, and now you're getting it from the last class all the way through to your exams. Nobody else has ever had that. So this should be a lot easier for you, and we should be seeing better results. If it's not easier for you and we're not seeing better results, I'm going to recommend we stop doing this, but I don't think that's going to be the case. It shouldn't be. But you do need to start not really revising. Like you need the information at hand, but you need to be using this in the clinic. And if you're not doing that, then it's got to look awkward in the exam. And at worst, you're going to screw up on the techniques. And I'm pretty sure, from my experience of this, that everybody who's failed this hasn't really failed on the etiology, because the etiology is a fairly small part of the exam as far as marks are concerned. But they failed because they couldn't do the techniques or explain the techniques, either assessment or treatment. And this is where people do fail. So that first part, the first 4 modules, really, the first 4 modules is where people fail. The rest of this stuff is usually not irrelevant by any means. But if you're borderline on the techniques, you're not going to, and you're borderline on the etiology, you're not going to pass this. If you're really good on the techniques and borderline on the etiology, you may pass it. But it won't be with the sort of mark you're expecting from school. So don't panic. Do you want me to say that in different words that are a bit sweeter, a bit nicer? I'm not sure I can.
Jim, do you mind if I add something about the exam?
Yeah.
So for me, guys, the biggest issue that I've run into where people really struggle is they don't get past the initial hypotheses phase, right? So typically when I come in, I'm going to give you a case scenario, much like Jim just wrote down on the screen, and I'm just going to ask you for 3 potential diagnoses. And when somebody really struggles, they don't get past that phase, and they don't get into enough techniques, and so they don't get enough check marks on the process in order to get enough score for us to actually pass somebody. The only other major significant issue we always run into is there's always the occasional problem with safety issues. That's the fastest way to fail an exam. But for me, and I should be at least at one of these exams, if you can at least get into the process, if you at least look and say, okay, these are the possibilities that I'm looking for. How do I test for these things? How do I treat these things? You're going to do pretty well for the most part on this type of exam. I would say that's a pretty good thing, a pretty good, reasonable summary from my perspective. I'm sure Jim would probably agree with me.
Yeah. You got the basic stuff you need to be able to spit out. You shouldn't be hesitating over this sort of thing. Shannon, like 3 or 4 diagnoses differentials for this should just come out. Okay, you shouldn't be hesitating over each one and wondering whether it is or it isn't. They just come out. And the faster you get it out, the more questions you're going to answer. So if you get through all of the answers, all of the questions fairly quickly, then we're just basically looking. Actually, what I do now is I stop the exam at that point. I don't carry on with it. If you've clearly passed this and you've got another 10 minutes to go, I just say, okay, go away. Because I've done it where I had a guy, I was testing one guy and he was really, really red hot. I mean, we finished the exam, is a 25-minute exam. We finished the exam in about 20 minutes, somewhere in there, 20 minutes or so. And I said, okay, one more question. And I asked him the question. It was a safety question, and he fucked it up, and it went. Basically, failed on that. The guy would have passed with close to 100%, and he failed it because I pushed a little bit more, and it was just one question, but he failed it because it was a safety fail. We don't do that anymore. What we do is we give you a whole bunch of things to do to try and recover from that after the exam. But if you get through it now, I've stopped doing it. If you get through everything now and I'm happy, I finish the exam at that point. I can't see the point in going on with it. All right, we've got time for Let me have one of your fellows here, Dave. One of your fits.
Go fishing.
They've gone fishing or you fishing?
If Zach is on there.
Okay, Zach. It's got to be quick, all right? We've only got 20 minutes for this. All right, we've got I'll give you the diagnosis. This is a right extension subluxation of L5S1. Okay, there's your diagnosis. Now I need etiologies.
Let's make sure he's on here first. Let's see if he's still there. If not,
See there, Zach?
if not,
I'm here. Sorry, I was away. What do we have going on?
Jim, give him the case.
Okay, so we've got, I'm going to give you the diagnosis, all right? This is L5S1 right extension subluxation. All right,
Okay.
that's your diagnosis. I'm your patient. Questions and tests for etiology, okay?
So you're coming in just with back pain? Is that what?
No, you've
So what
got the diagnosis.
I already have the diagnosis. Okay.
Yeah, that's the pain generator and that's the diagnosis.
This is for etiologies
Yeah.
specifically.
Yeah.
Any weakness in your feet or your foot?
What are you testing?
Like what specific segment? We can do L4, L5, or so we can do big toe extension.
Okay, all right, I'll go along with it. There's no weakness in the foot.
No weakness in the foot.
No.
Heel raise. Any weakness? Heel raise.
Sorry, in the what?
Heel raise.
No.
Okay. Any tingling? Lateral
No.
foot, plantar foot?
No.
None of that. All right. Moving up. Pain with walking?
The back hurts a bit.
Okay. And what phase? I'm guessing push off phase?
No, it's when I'm
No.
coming over the top of it.
You're coming on top of it?
Yeah, coming over it. Mid stance.
Mid stance. Okay. What activities make it worse?
All right. Why are you asking that?
It's a good question. I was just thinking of just what bothers it. I don't know. It's not etiology. You're right. And I don't know what I was thinking. Thoracic spine rotation how's that?
That's okay.
Okay. Hip mobility, internal, external rotation,
That's okay.
flexion, extension
Of the hip?
of the hip. Correct.
Okay, hip range of movement's okay.
So everything's fine from the hip. Everything's fine from the T-spine.
Yeah.
We have pain with walking.
Yeah.
So kind of like biomechanical, obviously issue segment of.
I've given you the diagnosis. You already know the diagnosis.
Correct. Yes. I'm just talking to myself, sorry.
It's not a good idea.
All right. Well, we can go into like functional tasks. We can do muscle strength.
Of what? You've already done the foot and the lower leg.
Yeah. Of the hips, maybe. I don't know if there's some kind of hip weakness, maybe when she's or he or she's walking. Trendelenburg or something that's driving into it. I don't know.
Hang on, why do you care?
Because I'm looking for what's driving the extension subluxation.
Okay, you're going to Trendelenburg for that.
Correct.
Okay, which side are you looking for weakness on?
Weakness,
On the
probably be
affected side?
maybe non-affected, and it drops. Let's see.
Let's say it's the right
Yeah,
hip.
affected
Which
side.
side are you looking for him to drop on?
It would drop on the left.
Okay, so why would that cause a subluxation of the right side joint?
SI joint or L5S1?
Sorry, L5S1.
So I'm thinking there would be probably a side bend on the right segment driving into extension and rotation potentially.
Yeah, okay. I think probably you need to look at exactly what Trendelenburg does to the pelvis and to the spine. I mean, all right, let me do this for you. I'm going to go mechanical, all right? So the first thing I'll do is look for a long leg. If I find a long leg, I'm going to look for the cause of the long leg, which will be the hip and the ankle primarily. If I can't find a long leg, I'm going to look for other mechanical stress on it, which is the SI joint. If I can't find that, then I'll start looking at neurological, neurophysiological causes, and then I'll start be looking around about S1. So I'd look at the foot and everything else, but it wouldn't, for me, be the first thing to look at. But again, this is a matter of organization of your exam process. You're going into it and you're just grabbing stuff, and I don't really understand how what system you're using to check on what. I would have, because what we was going to do, if it kept on doing that, I would have ended up with everything being negative. And then seeing what you would do at that point. So that's what I'm going to do to you now. Everything you want to test is negative. Now what?
So biomechanics, I guess, of the long leg is what we're talking about.
No, everything's negative.
Everything's negative for etiologies. This is a freak accident.
Every test you do is negative.
Okay.
You want to look at the strength of the foot and the strength of the leg, all of that's fine. You wanted to look at the hip, that was fine. The ankle's good. The foot pronates and supinates normally. The thorax is moving fine. Now what?
For etiologies? I
Yeah.
don't know. I would find whatever the driver is, whatever functional task, whatever they're doing that's driving this.
Well, yeah, what is driving it though? Everything you've looked for so far is negative. So what's driving it?
So everything, long leg, all that stuff.
Yeah.
There's no biomechanical thing that's driving this. But mechanically at that segment, I know there's an issue going there.
You got the diagnosis.
I don't know. I don't know, Jim.
Okay. Well, the answer is I have no idea. I need you to say that though. You like for this type of testing, this is what happens with when you do an expert test. This isn't you lot, by the way, so don't panic. All right. This is M9 or fellowship testing. This would be. So you keep on going and keep on going, and then we see how far you can go with it. And if you stop somewhere around about the point where I stop, then I'm fine with what you're doing. If you stop and I've still got 4 or 5 other things I can do, then I'm not fine with it. But it's how far you can take it. And that really does need organization. You really have to be organized to be able to do that. Okay, so again, it's about organization. It's not about knowledge. It's not about studying. It's about how you organize the information you're receiving and then how you organize your thoughts to deal with that information. Cognition. Okay. I've already got the tennis elbow thing made into a video. I'll send it off to you, Dave. Okay. Quickly, is there any other questions? Got a minute.
Hey, Jim,
Yeah.
I had somebody quick ask me a question, so I didn't get to hear your answer. What was your answer to Zach? You said everything was negative, and then what came of that? Everything, and you said, and then you all of a sudden said, I don't know.
Yeah.
That's after that. So if you know you have an extension subluxation, everything is testing negative, what were you going to do to move forward?
I'd manipulate the extension subluxation, but I couldn't do much about the etiology because I can't find it.
So would you?
But you have to ask a lot of questions about what they're doing. And sometimes if there's a sport, you ask them to see a professional coach to see if they're doing the techniques wrong. But as far as you're concerned with what you can handle, the musculoskeletal neurological side of this, you haven't found anything.
Okay. So how is that different than the elbow? Because like when we were talking about the elbow today, you had mentioned, you know,
Well,
don't just go ahead and manipulate it because that'll start changing
Yeah, it will.
findings.
Yeah.
So why is this different?
Oh, the difference is we found the causes. We haven't found the cause of the causes because we're not that nasty to you, but we found the cause at the immediate cause of his pain. We haven't got into secondary etiologies.
Okay. So because of subluxation is treatable. I mean, that is a treatable finding. We can
Yeah, but
address.
so is the subluxation in the spine. It's two
Right.
different cases though. We haven't found etiologies with the lumbar problem. We did find etiologies with the elbow.
But you would be okay with treatment without knowing the etiology.
Yeah, because I know there is no etiology that I can deal with. I've asked them to see a coach if it's appropriate. I did that with a pianist once, got a coach to look at it, he said, yeah, she's screwed up. So I've done everything I can do. I can't do any more than that. I can refer it out to somebody else. But if you're an expert, you're the person who's getting the referrals.
Yeah.
No reason why you can't refer it out if you want to. And in this case, I probably would. If I couldn't find an etiology for something like this, I would refer it out and make sure that I wasn't missing something obvious or subtle.
Okay.
All right.
That makes sense. I just wasn't sure if that would be a safety issue, but
That's not a safety issue. It's just a matter. There's nothing wrong with treating what you find, but you want to find also what's contributing and causing the problem.
okay. Okay.
Okay. By the way, I'll say it every time I've done this. The three of you certainly welcome to contact me if you want to talk about this on a Zoom session. Just get in touch and we'll set up a time. All right. Okay, I'm done. Not before time. Eric, if you want to chat, I'll send you an invite. All right.
Yep, sounds good.
Okie doke. I'll send it now. We can talk afterwards. All right, great. Thanks, Dave.
Take care.
Take care, mate. See you all.